Welcome to webcast number 4 from Mobile Health. My name's Mark Eager. This evening we're talking about recognising suicidal behaviour, and I've got with me Annette Beautrais and Steve Duffy, and I'll get you to introduce yourselves in a second, actually. So if you're online now, say hi and where you're from, and start typing now so we can see where you are from. So meanwhile, Annette, can you please explain where you're from and what you're about and your interests?
So I spent a long time living in Christchurch, but I now live in Timaru, and my background, the work that I've been doing since 1991, is in suicide research and prevention. And over the last few years, I've done a lot of work in educating people around recognising people at risk of suicide and intervening to link them to help, what can be done. And I've done that work throughout New Zealand.
Okay, thank you. And Steve?
So I'm a psychiatrist and I also work, so I practice psychiatry in the adult inpatient unit at Hillmorden, Te Awakora, and I'm the clinical director for the adult inpatient group. But one of my service sort of special interests is in zero suicide, which is an institutional combined quality project to reduce suicides in people under care of mental health services. And Christchurch is one of a number of centres around the world that's engaged with that.
Mm-hmm. So by way of background, the people we've got online tonight aren't from specialist mental health units necessarily. Most people are working in a rural area and don't have mental health anything in their title. So, but that doesn't exclude them from treating the whole person and doing that. Can we start off by talking about some of the definitions of because everyone talks about committing suicide, but that's not the proper way to talk about suicide necessarily, is it?
Right. So there is language that we prefer people to use, and this is really at the behest of families who have been bereaved by suicide, and they have asked us not to use the term committed suicide. So suicide used to be a crime, and the term committed suicide really is a legacy of those days, but suicide was decriminalised in New Zealand in 1961, and families have argued that it is stigmatising to use the term commit suicide because it is no longer a crime, and because we use the term commit in terms of criminal activity. So to commit a crime, commit a burglary, commit rape, commit adultery. And so the families have said they find it distressing and stigmatising that people still use the term commit suicide when it legally is not the case. So we've tried for many years to try and change the language around people who die by suicide, and the preference is that people say someone died by suicide, or someone took their own life, or someone killed himself or herself, and to try to avoid the term commit. And by the same token, we try to avoid the terms successful suicide and failed suicide, because again, that terminology implies that suicide was a desirable outcome.
That's right, yes.
Yes. So if someone died by suicide, then that's a suicide. If they didn't die, then it's a suicide attempt. And we shouldn't need to qualify it by saying failed or successful.
That's right, yeah. I think the focus needs to be on the state of mind, I think, of a person who makes a suicide attempt, and some of the descriptions I think that people used to use, like failed or something, they sort of take away from that focus on what the person must be experiencing immediately prior to making a suicide attempt.
So if someone's suicidal, are they depressed?
Not always. I mean, depression is very common amongst people who attempt and die by suicide, but it's by no means universal.
So why? I mean, if you're not depressed, why kill yourself?
So, I mean, obviously there's a group of people who have a variety of other psychiatric conditions, but maybe not to dwell on that group, more saying common things in the community that really do contribute to suicidal behaviour. There's very high on the list would be alcohol misuse. So people who drink more alcohol than would be recommended, are vulnerable to changes in their mood, irritability and impulsivity, and so they're more likely to get in arguments and fights. Their social circumstances deteriorate, their employment may deteriorate, and then they're coping even less with that if they're using alcohol.
So impulsiveness then is a
yes, and some people are more impulsive than others by nature, but yeah, some things like alcohol will increase people's impulsiveness quite a lot. And some circumstances, of course, where people are distressed will increase their impulsiveness, and that needs to be recognised as well.
Okay. I find it interesting because I suppose we all think that people end their lives because they're depressed, but in fact, there's a number of factors. So impulsivity, alcohol, drugs, all drugs?
Yes, as in a general category, you'd have to say that most drugs raise people's risk of dying by suicide. Yeah.
What about age and sex? Demographics.
Can I talk about that?
Sure.
So there is a gender difference in terms of suicide. Every year in New Zealand, about 3/4, 75%, the clear majority of all of our suicides are men. Women are more likely to make a suicide attempt. Men are more likely to die by suicide. And so that's referred to often as the gender paradox, the fact that women make more attempts, but men are more likely to die. There are a number of reasons for that, but one of the interesting things is that when I started out working in this field, which was about 25 years ago, then the male to female gender ratio for suicides was of the order of 5 male deaths for every female death. Now it is down to 2.5 male deaths for every female death. And that there may be a number of contributors to that, but increased use of alcohol may be a contributor, a particular contributor to that. And
maybe a dumb question, but is suicide rising?
Yes,
or is the reporting of it rising?
There is always some undercounting of suicide because a suicide is deemed a suicide on a coroner's verdict, and the coroner has to be clear beyond reasonable doubt. We don't use on the balance of probabilities. We use beyond reasonable doubt in New Zealand. So the coroner has to be clear beyond reasonable doubt that a death is a suicide. There is some undercounting, inevitably, and so it may, for example, be difficult to tell in a road traffic accident if it was suicide, or an accident. It may be difficult to tell in drug users if an overdose was deliberate or accidental, and it may be difficult to tell with older people in particular and overdoses if it was confusion and an accidental overdose or deliberate. So there is some undercounting, some under-ascertainment, but given that the major method of suicide in New Zealand, the dominant method, is hanging, there's usually, and 62% of our suicides amongst males and similarly amongst females are by hanging. There's less perhaps opportunity for undercounting than people think there is. It's usually fairly clear with hanging. And again,
not an accident, but I mean, what about the bridge abutment? 18-year-old argument with girlfriend on the way home. That would be put down to a traffic accident.
It depends. If there's any suspicion that it might be a suicide, then there is a very extensive investigation in terms of the speed and the condition of the road and the condition of the car, and the files are sometimes like this. And if the coroner believes it is a suicide, then they will give a verdict of autocide. But in some cases, it can be difficult to tell.
Just to give you an idea of where people are from today, so we've got Wanaka, Dargaville, Bay of Islands, Tokanui, but in saying that, Emma's usually in Stewart Island, Oamaru, Kate from from Palmy, Tauranui, Dunstan, Wairoa, Timaru, Central Otago, Kaikoura, Tararua Dannyburg, Dargaville, Central Hawke's Bay, So it's in Peasant Point. There you go. So it's a good mix from around the countryside.
Very rural. Can I, because you did ask me the question,
sorry,
I do want to talk about age.
Yes.
In terms of age, the public often has the misperception, because we tend to focus on youth suicide, and the media tend to focus on youth suicide. But about 10% of suicides are teenagers, 20% are aged under 25, and the clear majority, 80%, are aged 25 and over. And in terms of rates of suicide, old men, sort of 85 and over, are the group with the single highest rate of suicide. Many people believe it's teen males, but actually it's older adult, old males.
Why?
Very often there's been a recent bereavement. They've lost their wife, and if they're that old, then often they've been married 60, 65 years. And very often the wife is, they may have nursed her through a long illness, but often the wife is the social organizer within a family, and the children and the grandchildren, and they're completely bereft without her. So what I always say is, if you're working in a general practice, you need to be alert to people who are older people who are recently bereaved, and provide appropriate support.
Just before we go on to the next part, I just want to ask about geographical areas, because it would seem that Canterbury has higher stats, Timaru as well, with older people. So why are the geographical variations? And
part of it, as Annette was saying earlier, was that there are different demographics in different regions, and therefore you'll get the underlying shifts in that. So the national rates are published with an age adjustment. So you'll find there are coroners reporting of raw rates, you could call them, just of absolute numbers that occur in an area, and then you'll get so that'll be the National Chief Coroner's Report, and then also get the report from the Director of Mental Health, John Crawshaw. And his report will have age-adjusted rates, which even them out quite a lot. Small regions are prone to quite big variations in numbers from year to year. And that's just the nature of statistics. Small numbers vary a lot. I guess we can't be absolutely sure why a region like Canterbury would run slightly higher numbers. That also occurs in other countries, and I don't think it's easy to explain, even if it's a persistent effect.
I think we have to be somewhat cautious about having a league table of DHBs and suicide rates, because our DHBs were basically designed for geographic convenience, and making comparisons one to another is very difficult. And so, for example, if you have the West Coast or a place like Timaru, young people often leave that area, and you have a completely different demographic makeup. You compare Tairāwhiti in Northland with other areas, they have larger populations of young Māori who have a high suicide rate. And so that's why we have DHBs localising their suicide prevention and post-prevention plans to take account of different vulnerable, different demographics.
I guess we haven't commented about sort of social and economic disadvantage, and how that impacts on populations as well. And that is often regionally distributed.
And again, and many of these people tonight have come from rural areas, and although we have some debate about the definition of rural in New Zealand, generally the rural suicide rate is higher than the urban suicide rate. If you go to a place like Australia, then the remote suicide rate is higher again. So there is an increasing risk of suicide with increasing rurality and remoteness.
No, I'll leave it, because there's an obvious question coming here around connectedness, and we'll leave that for a bit later. Can we start by launching into identifying suicidal behaviour? Because I suppose that's the crux of the matter. Remembering that our participants are rural, often, as I said, they haven't got mental health in their title, that they're seeing Joe Public. What are the things that we should be looking for suicidal behaviour? So
I think the first thing you need to think about when you're trying to identify someone who thinks at risk of suicide is that if you just take a big population of people who go through medical officers and emergency departments and such, and look at people who've died by suicide, and you just go back on their last medical record, and especially if risk's been considered, you'll find that most people who die were considered low risk at the last time they were seen within our current model of service delivery. You have this issue that there's a very big population of people who don't have easily identified risk, just as far as we would currently see them, who actually most of the deaths by suicide are found amongst. And then you get down to smaller groups of people who maybe have an easily identified risk and might be seeing counsellors, psychiatric services, and then a very small group of people who are involved with specialist mental health services. So I think the issue for people who are working in rural practices, one, how to try and find out what's going on in this large group of people who don't seem to be particularly risky, and who to look for. And maybe there's a smaller issue of how do you monitor someone who you know has some sort of conditions that make you, once you're worried, that allow you, if you've got them ticking over, from month to month and year to year in a practice, and how you might identify how their risks might rise.
So there should be bubbles that pop up. And one of those bubbles that would pop up is an 80-year-old male whose wife dies, perhaps. That would be the...
Yes.
So when he turns up for his sore toe, he should be considered as a high risk, even though he's just there for his toe.
Yes, and I think it's worth using the idea of that's a high risk within general practice. They might not be considered high risk if they're sitting in a psychiatric unit, because they're with a funny toe or something. But for a general practice, you should be starting to worry. Starting to worry about people who are drinking too much, people who are having relationships breakups, and it may not be in the consultation that this information is coming across. I know that in rural practice, the informal communication and the practice nurse is often the centre of a great deal of information flow, which doesn't go on the computer. But that information can be useful in identifying people who you really think you should have a little bit more of a look at in terms of how safe are they feeling, are they managing the problems they've got in their lives, and what attention could be brought to bear on that. And a lot of what you're going to do, once you've identified that you think there's a bit of a risk here, is not talk intensely about suicide and methods and psychiatric stuff. You're going to be identifying the problems that come to bear on that person that lead them to be in distress, to be perhaps unsupported, and for them to be isolated and at those times. So
these are the relationship breakup. It's the open questions. You must be feeling crap.
How's your sleep going? It's
Yes.
always useful.
Yes.
And I think any man who presents to general practice should be asked about depression, and men are more likely to, within a general practice setting, to respond positively to questions around somatic symptoms. So sleep, how's your appetite? Have you lost weight recently? How's your energy level? Those sorts of things.
And then if you ask, are you depressed? I'd say no.
Yes,
but they've got a full house and everything else.
That's right.
Mm.
And so men may often go along after a relationship breakup, and a relationship breakup disadvantages men perhaps more than women. Men are protected from suicide by having a good relationship.
Mm.
Women tend to be protected from suicide by having responsibility for small children. So men are very much more affected by relationship breakup. And so anytime that happens, if you're aware of that within the community and someone turns up in the general practice setting, these are the questions you should be asking in terms of identifying depression, identifying whether they're managing and coping with that by drinking more because they're on their own and that sort of thing.
Yeah, I think a lot of the questions in the first instance are about the real problems that you anticipate the person might be facing. They might have real health problems, they might have chronic arthritis or disabilities or other whatever the problems are. It's worth asking about those. That really gives you the base work to then launch to questions about their safety. So you've asked about how they're coping and if they feel down all the time, can they look after themselves and such. And then you say, look, the situation doesn't sound very good for you. Have you thought you'd be better off dead? There's a variety of ways you can couch that question. But you're putting it in a context of awareness about what's going on for the person.
Because this is the I love you for the first time moment. It's a very difficult thing for people to spit out because it's to ask someone. That's a big question to ask someone, and often it's just easier to treat the toe and not keep on. So
it's easier to treat, and it can often, as skilled clinical staff have these things. You can be treating the toe and having a conversation about someone's life. And I think different people develop different styles of asking these questions, but you have the general inquiry, which is part of sort of a health practitioner approach. But it's just a question of how you lead next. You can preface it personally. Some people say things like, well, look, if I had all this going on, I'd be feeling really terrible, and I'd be worried about myself, being alone and out there. You can reflect it, you can ask it, directly if that's your manner and style. So there isn't a one absolute way of doing it, but I think it does come from getting to know the person, reflecting on their situation and the fact that they're facing a bunch of difficulties, and seeing, are they okay with managing that? Are they feeling safe? Have they thought? Do they have thoughts that life might not be worth living, whether they might end it? And once you're there, it's not a difficult conversation to continue.
But asking about a plan and
yeah, that's much more about having identified that the person's at risk, and I think then you're in a different clinical inquiry. So that's I think the difficulty is to get yourself to that point. But once, I think there are two ways that the person moves you on to the next point. One is they say, yeah, it's really terrible, I've been really worried, and then you immediately can go into a process of exploring the risk and look for supports and thinking about that. I think the other group of people to be really worried about are the ones where there's a long silence, or even not such a long, there's a silence, and then they sort of say, oh, I'm all right. You have to say, well, I'm not. I didn't like that silence, So this, again, it depends on your personal style, but I worry, when they've been chatting away, talking about things, and you talk about something which goes a bit deeper, a bit more difficult, and they go quiet, you have to say, well, that I think that quiet means there's something going on here. We need to talk a little bit more. So just that would be another thing to consider.
So will people always say? I mean, that's because people just lie.
Yeah, although they've come into the general practice setting, let's say we're talking about that, and I think generally they are relieved to be asked the question. I think to always think about people who bear a suicide risk, and once we've got to that point, we think that's an issue. They're always ambivalent about suicide. You don't get someone sitting in front of you who is utterly determined to commit, to commit themselves to something. That if someone has decided they're going to act, this idea, well, can't stop them because they've already decided. This period of time between them making that absolute decision and acting, in various studies, there's something like between 20 minutes and sort of 2 hours. It's a very short period of time. People don't go around in that state of mind for very long. So what you're almost always seeing is someone who's in an ambivalent state of mind. Sometimes they'll be tootling along sort of okay, coping. Other times there'll be the darkness of the night, they'll be alone, alcohol on board, and there's things will be swirling in their heads, and they think, I can't cope with this, I can't deal with it. I've got to do away with myself. And so what you're seeing is someone in this evolving, sort of fluctuating presentation, and they haven't made up their mind, but they're in two minds. Okay, so that's what, and it's really important to bear that in mind in the conversation, even to say, look, it sounds like on one hand you think all these terrible thoughts and you can't cope and it's not going to work. On the other hand, you get up and you phone your mum, or you go to work and you talk to your mates and you do this. So this is difficult. This is not. This is a mixed situation that you're in, which is difficult to bear.
People tend not to lie in this situation, particularly if you ask them the question directly. So if you set it up by saying, look, lots of people in your situation with these sorts of problems, it would be common for them to be thinking about suicide. Are you thinking about suicide? And people, when they say that when they are confronted with the question directly, feel compelled to be honest.
Right.
And in many cases, they're immensely grateful that you've recognised the distress and ask them the question, because we don't train people to come and tell us that actually they're thinking, they've got all these problems they can't solve, they're thinking about suicide, can we help them? And until we can change the culture around encouraging people to come and tell us, we have to be more alert and we have to ask them directly. And by and large, they're very, very honest.
Now, Annette, you before said, you gave some statistics about how often people see health professionals
Yes.
before they suicide.
Yes.
So there's a pattern, isn't there?
Yes, the general rule of thumb is that about 75% of people who die by suicide have seen their GP at least once in the last year. 50% have been to see their GP within the last month before they died by suicide. And more than 1 in 4 have been to see their GP in the week before they die.
So that's
many
huge.
of them within
That's massive.
1 in 4, many of them within the last few days of the last week. They don't always come in and say, I'm thinking about suicide. And they often present with no particular pain or problem, but they expect the doctor or the practice nurse as the expert to divine why they're there. And the other interesting thing is there's a research paper out from the States a couple of years ago which said that on average, the people who had died by suicide had been to see their GP 16 times within the last year. So that's about a visit every 3 weeks. So there are lots of opportunities.
And I think emergency department presentations are sort of similar in the statistics, and that people who go to the emergency departments also are at much higher risk.
Yes.
We've got a couple of questions actually, so if we could just divert to those for a minute, and then we'll come back. So Rhonda from Central Otago, Dunstan, we regularly see admissions by suicidal intention. They've all had mental health review prior to discharge. How, as a rural hospital nurse, can I use that time I have with the patient to develop a report or assess risk?
So this is people who've been discharged from mental health service recently.
I think that's what it is.
Inpatient service, and then they're at their general practice and they've still got suicidal ideation.
Yeah, and she's saying that these patients are withdrawn and at times challenging and hard to engage. How do you develop a report?
So, presumably they are patients of the practice that are returning, having had a mental health visit, and presumably also you want to be aware of the documentation they've got around the reason for the admission, how the admission went, and what the aftercare plan was, which may include some follow-up with the psychiatric case manager in addition to general practice contact. I think one of the things that's really useful when you're approaching somebody, they've obviously been assessed, and it's not a question of some fresh, looking at things with fresh eyes so much as trying to deal with an ongoing situation of distress and concern, is trying to figure out what the person needs or what they want, and asking them pretty directly. So you've had a hospital admission, some things have got a bit better, it looks like, from the note, but you've still got all these other troubles. What can we do today? What can we try and put in place that's going to help you get them to identify and work with you about what might be useful? I'm not, it depends, of course, on the resources of practice.
And I think Rhonda's saying that patients in hospital, in the rural hospital.
So, in the rural hospital.
Sorry, so just clarifying that, and she's the nurse. So it is that. I mean, we'll talk about practicing about talking to people about suicide in a second, because we've done that successfully around the countryside, Annette, haven't we? One of the questions has come through about when we say previous encounters pre-suicide, they've been identified as low risk, and the question is around direct questioning about suicidal intent. So that's the next step. So once you've established that things are really bad, life's not worth living, we ask about a plan, and
so you ask about how the person's thoughts are progressing. So you would like to know how long they've been thinking about this. I think when you're still just talking about sort of suicidal ideation, just before you get to plans, it's worth trying to get a bit of a gauge about whether the person can just stop thinking in this way. So people have ideation which comes and goes, and they might reach for it at times and think about it, and they might be able to dismiss it from heads. I guess ideation which just keeps coming into people's heads unbidden, which they can sort of dismiss. They say, I can stop it, do the dishes, I can sort of stop it. We call that sort of preoccupation. So these are recurrent thoughts, come unbidden, but you can distract yourself from them if you're doing something that keeps you off that track. And then we talk about people who can't stop themselves thinking in this way. We call that ruminations, which is a type of thought disorder, really, where a person can't stop these thoughts. And often the thoughts are how bad things are, how bad they are, how they might as well die, and then goes round and round in circles. So that's quite a serious situation if someone has ruminations about suicide, and I think that requires medical review, because there are some treatments we've got which can truncate that quite effectively, and it is very dangerous to have someone just not able to stop themselves thinking like this. Common into quite severe depression, and even moderately severe depression, and quite treatable as well. I guess that I think if you've sort of identified their sort of pattern of thoughts, you're wanting to look at what their plans are, and so you ask them, have they got a way they thought of themselves, and just inquire gently as to what that is, and just you want to go through right to the details and say, so you've thought of hanging as a common one. Now, have you got a place where you think you might do that? Have you gone and looked at it? Then you say, well, have you acquired the means? So some people might have got a rope and some other equipment that they think will be necessary to complete that. Have you ever tried that before? So sometimes you find that they've made, they've gone to the place and set it all up as a dry run and stuff. You're getting more and more serious stuff here, and then after you sort of feel that you've got that, because you really should want to check, are there any other means? So it may be that they have two or three means in mind. So it is worth, and it's worth cueing people about comments. Have you thought of overdosing on medication? Have you thought of shooting yourself? Have you got access to a weapon?
So trying before, is that an increased risk the next?
Yeah, so that's before we sort of really go back, but more just sort of dry runs within the time we're talking about, this immediate period. Right. Then all the other methods that people jump off high places as well, and so often you've found people have gone to high places and stood there for a while, and then a car will come along and they'll go away. So these are very high risk sort of scenarios. I guess once you sort of feel you've got a good grasp of where they're at, how far they've gone along these lines of thinking, now you really then want to know about any past events. So there's a Sean Shea who's worth looking up on I'm sure he's got a YouTube video on his method. Is really really lovely psychiatrist, and he's got a lovely method which is the arc back to the first time in the life the person had a suicidal ideation, and you work through all the times before. I'm not saying that a practice nurse in the rural sense is necessarily going to do that. I think you need to try and figure out how far things have gone just recently, and you need to know if there's been any previous attempts, because they greatly raise the risk. So that would be around the suicidal ideation itself, but there is, then you also have to know about, do people have, alcohol and drug problems, have got a major mental illness going on? And that's one chunk of stuff, and then the main thing is what's countervailing, what are their supports like? Because people can bear quite a degree of risk, and if they're in well-supported environments, if there are people around 24/7 who know and love them and know what's going on and keep them safe, you can bear greater degrees of risk in the community. But when a person has all these factors, that is that they're very advanced in their suicidal ideation planning and preparations, and then they've got a whole lot of factors, which we'll probably talk about more, and they don't have supports. They've been bereaved, they live alone, their alcohol's got rid of all their relationships or something, got rid of their job. That person, maybe look relatively not so far prepared, but they're without supports. Then they're sort of unbuffered in the community, and that person would be at considerably more risk. Yeah. So that's the sort of general way of trying to understand what the risk is.
So is there a grading scale? It's like, because I can imagine, knowing a lot of these rural nurses around, we've talked several times since we've been here about Friday afternoon, and someone's just popped in for their verruca, and you're dressing it, and you're uncovering all this.
Yeah.
Then it's, well, so what? Where does the burden of responsibility lie then? What happens?
I think once you've identified the risk, you have to have a reasonable management plan for that risk.
Yes. Because there are there's no standards, or there's no, rip something off the wall and open, turn to tab 4, and this is what we do. This is an issue, and with poor resources in rural areas, it's what do we do?
Mm. So I think if you're concerned about anyone, you should talk to another health professional about it, preferably somebody who's more senior than yourself. Mm-hmm. But it depends where you are in the system. You shouldn't have that burden alone, even if it's a telephone call, not someone in the actual practice. should have a discussion perhaps with the psychiatric team or with your GP if they're in.
So if they're sitting in the practice, don't let them leave.
So someone who's high risk, you shouldn't let them leave alone. Yeah, you should have a good understanding of their risk and how that's going to be managed.
Meanwhile, you're on the phone to somewhere.
Yeah, so I mean, so on one hand, you're going to be trying to get some sort of psychiatric approach to that risk. So let's say that we think very high risk and lots of things going on, then you would want to talk to the GP about referral and the psychiatric team. I think the other thing to be thinking about at the same time is to call in someone who knows this person and can support them, because it's not just about mental illness treatment, it's about the person being supported in the community. So so getting someone who knows them into the practice, or at least on the telephone, I think is number 2 on your list of things to do, people.
And thinking of the 80-year-old, it might be a neighbour or a mate or a daughter or a...
Yes.
Yeah.
Yes, absolutely.
Okay. Legally, where does a health professional sit? What are the risks do we have when? Because this is quite. I mean, it's life and death stuff here, and we're used to giving the right drug in the right dose in the right place. But this is quite different. I mean, your decisions that you're making are quite, and sometimes it's very easy to kick to touch because you phone. I'm concerned. You phone the local mental health team, the police. And who else would you use in a rural area, Annette?
Oh, maybe.
Me? Okay, so yeah. So your police the police won't really do anything other than do things like transport, for absolute safety issues. Or, they could be someone, if the person leaves the practice, if you say, look, I think you should stay here, wait in the waiting room, go have a consultation with the GP, and they shoot through and hop in their car. Obviously, the police have a real role there in doing safety checks. And that's
so like going around and removing guns and...
Yeah, but they'll also, I mean, they're a group of people, if the police go and knock on the door and are concerned about your safety, they can do Section 106, where they can require the person to go to for a health check at a psychiatric service. Yeah, so that they have more powers to compel than a practice nurse can easily access. I mean, there is, of course, the Mental Health Act in the GP system as well, but often people are out there roaming around.
So one of the questions has come through is the trick is convincing the next service that this person's a priority. And that is because you may be scared shitless because this person is, as far as you're concerned, really not well. When you're doing physical checks, and you can say, I've palpated, blood pressure is this. How do you convey the information to the next service? What are the? So
I think a lot of staff who are practice nurses don't have mental health training, and I think they're not confident in doing the basics of assessment that would allow them to communicate confidently and perhaps effectively with a mental health service. So I don't think it's enough as a health practitioner to just say, well, I think the person's high risk and it's a terrible situation, so they should sort that out. I think as I sort of discussed the type of information you need to collect, and I think it's worth reading. It's probably the highest level you would need to achieve in rural practice. But the Pisani article, which we've attached to this.
Andrew, could you just throw up the slide? Andrew's going to put up a slide. So Andrew, so Steve's given this example, and you should see the screen now.
So that's a one diagram out of an article which is free online from Anthony Pisani about risk assessment for suicide risk. And the article, in fact, is sort of primary psychiatric contact it's aimed at, but the discussions are nice. The interview has an interview in it. It has a discussion about risk, and I think that's the ultimate level that you could, not something every nurse could get to that level in a rural practice, but that structured approach, understanding about the person's background, whatever sort of static factors they have had, them to know whether they've made a previous attempt, do they have a long history of mental illness, and then know about their current situation, and then have asked some questions about their thinking and how preoccupied or ruminating they are, and how far they've gone in making plans and preparations. if you have a conversation on the telephone from that perspective, you're going to be a lot better received by the mental health team than, oh, look, I'm really worried about Mr. Jones. He said something about suicide and he's not himself and his wife's worried. Simply saying you're concerned is not an assessment. So I think that people are obliged to pick up the information in that sort of picture to communicate effectively.
Mm-hmm. So we'll send that link out on email to everyone, so you can have a copy of the link to the article, so that we can go through that. Interested to know if people would be interested in some workshops on training for this. We've done it once before at a Rural Nurses Conference. It was very good. And I think role-playing these things are the best way of getting practice. Just practice. It's exactly the same as doing a physical examination where we practice heart sounds and palpations and stuff, but we don't practice the hard questions with a variety of people as well. Just another question. Is there any urgent phone counsellors who can speak to the patient directly within 12 to 24 hours?
Yes, there is now.
Yeah, well...
So there's the 1737
so
number.
Steve, hold it up, Steve, just by your face. Sorry.
Oh, by my face.
Yeah.
So these little tags are available for people, and that's a telephone counselling. Well, run out.
Yep, I think they gave the last one to the Duchess of Sussex.
She'll take it somewhere where it doesn't work.
Yeah.
So 1737. I mean, there should be posters around available for that. So that's a telephone counselling service.
So that's part of Healthline, and that's 24/7.
It's available 24/7. You can free text or free call anytime from any phone, provided you've got coverage in rural areas, to 1737. It's staffed by more than 90 very experienced mental health counsellors or experienced mental health nurses. They can take calls in over 40 languages. They'll do brief counselling on the telephone if they have to. Otherwise, they have the best directory available of local resources within every area, and they'll refer you locally. So they're available. And you can also call your local DHB, your nearest TACT team, Psych Emergency Team, Crisis Resolution Service. They call different names in different DHBs. But you can certainly talk to them within an hour, if not certainly well under 12 to 24 hours.
The issue in New Zealand, we don't have one point of call for, if you're having a heart attack, everyone knows the number 111, but for psychiatrics, I suppose it's 1737 is the...
And then your TACT team, your DHB mental health crisis team. In an absolute emergency, of course, if you think the person is of imminent risk, then dial 111 and they'll triage all the emergency services to you.
And at Field Days this year, you were doing some research on issues, mental health issues in rural areas, and that was a very interesting piece of research. Otago University were doing one as well. I found it really interesting that both research outcomes were the same. And it was around completely different approaches, but the issue is the same. And for rural areas, it's that connectedness that people find. And in rural areas, you lose your school, you lose your the pub, you lose your rugby club, you lose the church. The commuters come into town, and then the social fabric falls away, increasing in alcohol. What has connectedness got to do with suicide? Is there a relationship between the two?
Yes, there is. And just going back to that research, it was really interesting because people said the biggest problem they had was work stress, and the second biggest problem was loneliness. The second most common problem was loneliness. So yes, people are, and it's paradoxical because people have never been so connected in terms of having friends on social media, but at the same time, they describe themselves as being very lonely and never been more alone. And there's an increasing amount of research that suggests that your friends on social media are not the same as having person-to-person, face-to-face contact with people in terms of social supports. And so a third of New Zealanders now live on their own. And some are happy to do so and choose to do so. But for a number of people, it's a lonely place. We have much more geographic mobility than we used to. It's only a couple of generations ago that people really didn't move 7 miles from the village in which they were born. And now we have enormous geographic mobility, and we have particularly older people who may have 3 children, and one lives in Australia and one lives in the States and one lives in the UK, and they will say, you know, they're too busy and the grandchildren are too busy to Skype me. And so you lose that sort of connectedness. And then, as you say, we've removed from rural communities all of the previous social hubs. So we've closed, 400 schools in New Zealand over the last few years, many of them in rural areas. The drink driving laws mean that rural pubs are no longer viable, and rural GPs will tell you that the rural pubs have closed and now people drink at home, and when they drink at home, they drink more. So that's more of a problem. And so when people feel isolated and not supported, then they feel that life isn't worth living. It impacts on their quality of life, and in that way it's related to suicide. The UK has just appointed a Minister for Loneliness and a Minister for Suicide Prevention because they regard it as such a problem of current society. Just a wee note here, Tanya's looked up Dr. Sean Shea and saying he's great. So, Sean Shea is fabulous. Yeah, he's a lovely person, and his approach to asking about suicide, he has a book called The Practical Art of Asking About Suicide, and if you want a textbook, it's very, very good. But he presents a pre-conference workshop at the American Association of Suicidology every year, and it's always sold out.
It's such
yes.
Okay.
Oh yes,
an old-fashioned term, really. I don't think it's popular now, but they got around to changing it.
Yes. But he gives a wonderful talk about suicide.
Now, the cure for suicide. A silly question, but I mean, we've talked about recognising. So, is it connecting people and medicating people? Is it the short answer? I mean, would you always medicate? I mean, I'm doing this with tongue in cheek, but because often it is.
So, as you progress down the level of severity of problems, you tend to have major mental disorders occurring, and certainly you go from depression, for which mild depression, you probably adopt counselling as probably the best strategy, through to moderate and severe depression, which often has the rumination stuff. We just take that illness, then yes, once you get into moderately severe mental illness, medication is really important in relieving people of symptoms.
Top tips for medicating someone?
It's a little hard to say that there is a medication strategy which specifically relieves suicide. The issue is quite complex. I mean, the 2 drugs that are demonstrated to reduce suicide rates in patients with major mental illnesses are very much psychiatrist drugs, clozapine and lithium. Probably the broader prescribing of SSRI antidepressants in the community is a good thing in terms of reducing suicide rates.
It can also increase it though, can it?
Well, that's a very interesting question. Certainly in the adolescent groups, that's been considered to be a problem. I think that you should always monitor a person for how they're progressing. And if they get worse, you're going to have to change the treatment. One of the issues with the SSRI antidepressants, which happens less commonly but is quite a problem, is a condition called akathisia, where antidepressants and other psychiatric drugs can cause a form of restlessness that's quite uncomfortable. It doesn't actually necessarily manifest with much movement initially. And
so that's the pill rolling in the tongue?
No, that's start of dyskinesia. This is just more like people feel uncomfortable in their limbs and feel like moving them before they get a more severe form of actually start pacing around the room all the time. But it's that mild akathisia, which can occur on SSRI sometimes, which really does make people feel quite bad without being very clear what's happened to them. They just feel
jumpy legs.
Yeah, it's related to the myoclonus that people get in bed at night, but it's not the same condition. So it's just you have to watch out for that with SSRIs. It's quite uncommon, but if people deteriorate on an SSRI in the first week, and you should see them within the first week when you start it, then you either have to use a benzodiazepine or switch them to something else. So that is a sort of hidden problem with some of the antidepressants, and I think when you look at the really big trials of antidepressants and reduction in suicide rates, you find that in America they had this study where it showed that the suicide rates dropped when they were given a placebo. And that's not because people received a placebo and it worked magic for them. It's because they received case management at the same time. So treatment as usual, but without a medication, included seeing a psychiatric nurse or social worker, talking about their problems, making a treatment plan or a management plan, being followed up, getting social assistance, the telephone calls and everything like that. So that social support is probably, certainly in the first weeks of treatment, is far more important than antidepressant selection. So,
So how do you stop someone repeating this again? What are the... I mean, is it likely that people, I think you said before that people have repeat?
Yeah, so for someone who's had a terrible period of time with suicidal ideation, who might have made a suicide attempt, I think the period of time when they're well and they've recovered is a good period of time to actually work with a person, because they're not ambivalent about surviving, and to make a plan, to revisit the plan, the action plan that you have, or the crisis plan, as it might be called, for what to do if they get like this again.
So there's a line where, when you get to here,
yes,
start waving your hands.
That's right. So we say, look, when we look back on this, you'd had, you're drinking too much, your relationship went to hell, your wife's actually come back fantastically, your job was in threat, and you seem to get depressed, and and you had all this stuff happen. So when the things are looking a lot better, you want to say, let's reflect on that time. What are the red flags in your life for this happening again, and how do we work with you to turn that around at an earliest juncture as possible? And I think that it's a good opportunity. So rather than just say, oh well, it's gone, let's not worry about that anymore. It's just a good opportunity to revisit and clarify an action plan, and to work with the well person to keep themselves well.
What are some good online resources that that practice nurses and patients can use for helping themselves?
Well, there are lots of resources at depression.org.
Yes.
Some people call it the JK website because it has used John Kirwan as a model for getting help about. And there are lots of things. If you actually go onto the depression.org website, the first thing that they will ask you to do is a depression screen, and they use the PHQ-9, which is the patient health questionnaire, 9 items, and that's the depression screening tool that is most commonly used in general practice in primary care in New Zealand. So, and then they will work you through a safety plan, exactly that you've been talking about. There's the journal. There are a number of resources there. There are resources that are appropriate for young people. There's the lowdown. And there are resources for family members and friends who are supporting someone who has problems. So that's one site.
Yeah, ALEC is another one. A lot of people with drinking issues. ALEC's got a website which has got education and support. I think that's sometimes the issue can be for people who've got sort of troubles and ideation, but things are sort of okay, and they're trucking along, and you're worried about them. You want them sort of to be better and more well, but you're not really treating depression or treating this. So for males, we've talked about that. The one from
Headspace.
Headspace.
Andrew, would you like to
Headgear?
Headgear. Yeah.
So that's a Black Dog, which is Australian Institute, which is great. And also Beyond Blue, which is the Australian equivalent of depression.org. And this is a sort of more of a, you might sort of say, a wellness and a stress management set of tools.
For blokes?
For blokes. Yes. It's very acceptable to guys, the way it's styled, the conversations, the voices that are used. And it's got a package of 30 days of little activities you can do each day on your cell phone. So it's a resilience building tool. So I think often that group of people where there's been some stuff and we just want to try and make things better, and there isn't a counsellor and there isn't something like this is certainly a useful thing to start. It teaches some mindfulness exercises, how to relax, how to sort of sort themselves out and clear their heads a bit, for people who are basically resourceful but aren't very psychologically minded, you might say. So it's a good entree for them.
What about tools for general practice? I know in Canterbury we have Health Pathways, which is a kind of an algorithm, isn't it, on how to treat someone? Is suicide included in that? Yeah, so and it has sort of steps for identifying and then managing people at various levels. Are they up to date?
Yes, no, those pathways are.
I think many of the PHOs around the country will have what are these? There's one called map of. It's a map of world, but no. There's a variety, and they all lead down the same paths. I think, which is that. Beating the blues on medtech is excellent, says Tanya. And the resources for health specialist resources for health professionals.
I'm not sure online. I don't think they're well organised.
Can I just say, mobile health webinar number 4 is this one. It's a start. When we go to conferences, mental health, I don't think really comes to the fore a lot. There's a little bit of chat about it, but it doesn't. I don't think there's a lot on that.
It's government policy really that mild to moderate mental health is managed within the community and within primary care.
Mm-hmm.
So it does. This is what the nurses and physicians in primary care are being asked to do. Without a lot of training. So it should perhaps feature more commonly in terms of speakers and pre-conference workshops at your conferences.
So I think the mental health review is likely to come out. They've got suicide prevention as one of their listed targets, and they're likely to come out with more recommendations around community resources and training and stuff, but I can't preface, I don't know what they'll come out with specifically, but I do think it's worth watching for that. That'll be early in the
new year.
I can also say that the mobile health video teaching that we do across our studio, where people can pick for a town, what we've found is that we'll have a mental health day, and they're particularly popular, especially when you get GPs and nurses, practice nurses and district nurses all in the same room talking about this, because here we are, everyone's at their home with a wine in their hand, but when you can sit down with someone else and have a case study and talk about, well, let's talk about Bob. How did we handle that? Was that a good thing? And you can dissect it. It's a very good thing as well. So
yes, and it's also establishing connections within the community, so that in the event of a crisis or a suicide cluster or something like that, you know who else has a similar training, similar background, is interested, and that's very useful.
I think one concept that seems to be coming through when you look at some of the mental health services internationally that are having reductions in suicide rates. Suicide prevention seems to come from doing a lot of other things well. It's
all at the same time.
All at the same time.
All got to be done at the same time.
Without gaps. I think there are some very specific therapies that have got demonstrated value for high-risk populations. But I don't think they're the focus of today's activities. But I think the general rule of thumb is that people come with distress, they have problems, they may well have some sort of mild to moderate mental illness in a general practice setting, but it's about finding out what all the things are, understanding them and seeing what can be done and being consistent and following things through. That in general is going to produce results. It's not sort of a magic drop of some potion or thing that you do that stops suicide. More like that you take away the things that are pushing someone in that direction and put up barriers and supports.
Going back to that connectiveness, there's a GP in Northland, Tanya Kemp, and Tanya, she talks about too much hooey and not enough doey, and rather just talking about it like this, she organised a do in a local hall and tried to get the connectiveness together, and everyone had a party, and then they went out and found who didn't turn up, and then and had conversations with them, so trying to bring everyone together. Raglan had an issue with a cluster of suicides as well, and their community kind of put some emergency plans in and did that connectiveness. Who can we talk to? What can we do? How can we do it? And it's that bonding of the team. So
but that has to be sustained, and very often it is reactive if there is a suicide or a suicide cluster. And what we really want to do is build that as a community strength in a proactive way to try and minimise the risk of suicide.
So the Godman Study, which was an island, Swedish island, which had a reasonable sort of population, was sort of rural really, they put in, there's many years, a few decades ago now, they put in a lot of training for GPs and nurses and community resources around treatment of depression and suicide prevention, and they drop the rates, and then they
In women only.
right,
Because women go to the GPs more than
and then they stopped that, and then went back 10 years later or 5 years later, and the rates just crept back up again. So
yes.
if you're not, just to say, that there are things you can do, but it's this continuous, seamless nature of it. It's not
changing,
a fix.
That's right. It's changing the culture and having sustained approaches to suicide prevention. So training, there is no mandated training in suicide prevention for any health profession or any health social service provider professionals in New Zealand. So that's one of the things that you could do as a local GP practice. Just say, we're going to do suicide prevention training every year. And you actually sustain it. It just becomes a routine part
It's like
of your
CPR.
training. Exactly.
Yes, or
It's mental CPR. It's the equivalent.
Yes.
And you can't practice without your CPR accreditation being up to date. And similarly, you
save as many lives potentially.
Absolutely, if you actually keep your mental health and suicide prevention training up to date.
Yeah, I think we've given everyone some ideas as to some practical ideas, hopefully. A couple of last questions. Tanya's recommending that BPAC have some good professional tools. A question going back to the people that are presenting to GPs prior to suicide, the 25% of the week before, were the questions asked, or did they present, or was it just they just turned up for a cough, cold, or a sore hole?
Well, it's very interesting because they did some research with a group of these people, and they didn't come in and say, I've got a ton of problems that I can't solve and I'm actually thinking about suicide and I think I need some help. They came in and they presented without a particular problem or with a minor sort of query, and they expected the doctor or the practice nurse to ask them if they were there because they were thinking about suicide. And when they did the research, and because a number of these people then went home having not got the help that they were hoping for and did make suicide attempts but survived them. And so in this research project, they interviewed the patients and they interviewed the doctors and they looked at the medical notes. And the patients believed that they were conveying or telling the doctor by not presenting. And when they interviewed the doctors, they said, well, look, the patient came in and they didn't present with a particular problem. Did it occur to you that they might be there because they were distressed and thinking about it? Well, it crossed my mind, but I really didn't want to embarrass them or offend their dignity by raising the issue. So it was, and then often the content of the consultation was about trivial sorts of issues. So it was a missed opportunity. And so you need to be alert to the possibility and always ask about suicide if someone presents with...
A bit like the meaningful silence.
Exactly.
Vague wandering
consultation. And at the same time, we need to try and encourage people to go to the doctor and directly say, I think I need some help. I'm thinking about suicide. But until we change the culture around that, then we need to have a primary care workforce which is confident and competent about asking about suicide.
We're bang on time now. So Annette and Steve, thank you very much for your time tonight. Team, thank you very much for taking an hour out of your evening tonight. I hope it's been worthwhile. My take-home message and my recommendation to everyone is consider suicide prevention training like CPR training. You need to engage your local health professionals. Get someone like Annette along to run some courses for you. After being through one of Annette's courses and just reinforcing, role-playing how to talk to someone and a whole lot of different people, because we had 85-year-olds down to children, to young people as well. A very good way of doing it. After some suggestions for next webinar, we're up to webinar number 4. Number 1 was bugs. Number 2 was Alaska. Last time was clinical supervision. Suicide prevention this time. Keen for some, if you can type now please and let us know what you're keen for next time. So after all that, thank you very much. Signing off now, and we'll see you next time.